Professor Dan Stark from the Leeds Institute of Medical Research right here in Leeds, and he's going to talk about history of GIST before drugs, and you are very welcome.
Thank you very much indeed. I'm going to start from there, and then so that it's useful to people increasingly in the room, I'm going to walk through from there. It actually interdigitates better with Alex's talk than I would have expected, so thank you very much. Those conversations clearly worked in preparing for this. Thank you to lots of familiar faces in the room for having me here, I'm not going to choose a sort of very traditional sort of talk. I'm going to start with some key fundamental things that I think are important about GIST and where we all came from, and then move through how we've evolved to have these sets of drugs, and then neatly segue into trials that are active or about to become active at the moment, including mentioning in passing the study that has just been mentioned here. So I first began looking after patients with gastrointestinal tumours in the 1990s, in the late 1990s. And at that time, we didn't know anything about this illness at all, really. We knew that the treatments that we had really didn't work. We knew we had surgeries for people, but there wasn't much else, and I'll show you some information about that in a moment. And it was like quite a lot of cancers at that time, but it was one of those cancers where the situation was desperate and miserable, and where people got their GIST again, it was extremely hard to help them further. And then I was at a meeting in the States called ASCO, the American Society of Clinical Oncology, which is an enormous cancer research meeting. And by enormous, I mean it often has 55 or 60,000 doctors present from all over the world. It's held in a thing that looks like you walk into a big airport and there's one of those enormous rooms. You put sort of 4 or 5 of those together, and that's what it's like. And in one part of the meeting, it has posters, which are a bit like this thing here, yeah, which are people presenting new research. Yeah, and one poster at ASCO when I went had probably 3,000 people trying to see it. Okay, and they were all shouldering, can I get to the front, can I get to the front? Yeah, okay. And this was somebody who had done some work which showed that this new medication, STI 571, could be given to people who'd had GIST for some while and who were in a lot of trouble with their GIST, very, very, very ill with it. And what it did was quite remarkable. Okay. It rescued some people who would be expected to be in the last couple of days of their lives, yeah, who got up a week or two later and went home. Yeah, okay. It was a really remarkable thing. It was by far the most remarkable thing I've seen in my career that this was the case. Yeah, the medication was quite difficult to use in people who'd had GIST for a very long time. Some of these people had 12, 15 operations on their tummies over years. Yeah, okay. And it was quite difficult to use in that group of patients because it killed the cancer so quickly that sometimes their previous operation sites fell apart. Yeah? Okay? Yeah? Okay? Because the cancer was actually holding things together inside these unfortunate people. Yeah? Okay? So it was really very dramatic and very exciting. So I went away and started to find out what had happened. And what had happened is in the Far East, in Japan, some scientists were working on patients who had a particular family history, yeah, of a particular problem, which meant that they got these GISTs, yeah, and they also got some other illnesses, yeah. And one of the characteristics was that their children, when they carried this particular abnormality, were born with this characteristic change in the pigment on their foreheads, okay. And somebody working in Finland had identified that the animals that they were doing biological science using, there was also a group that characteristically had a white patch on the middle of their heads. Yeah? And these guys got together and said, oh, that's interesting, what's all this to do with? And they discovered that it was due to an abnormality in c-KIT, which Alex told us all about. Yeah? Okay? And that's where it all came from. They discovered that a drug that had actually been devised to treat leukemia, yeah, STI 571, actually blocked signalling through c-KIT, and that's how Imatinib came to be. Yeah, that's how Imatinib came to be. We're still learning. We're still learning even now. This is January of this year in Nature. Yeah, still learning about how c-KIT mutations from families that carry them, yeah, identify different sorts of patients who have different sorts of GIST. It all continues, the genetics still continues to teach us things, to help us look after people living with and after GIST. No? Another one? Thank you. I'm going to show you a few of these graphs. Because I think they're useful. Yeah, okay. They map from a group of people who remains either well or free of their cancer or alive as time passes. Okay? So where you want to be is along the top and to the right-hand side, and what you don't want to be is to the left and to the bottom side. Okay? Yeah? And this is a poster, a presentation from ASCO shortly after that incredible poster which everybody wanted to see. And this is the very sad, difficult blue line. This is for people who were receiving ordinary chemotherapy, doxorubicin chemotherapy, which didn't work at all. Yeah, okay? And this is what happened when people were given Imatinib. Yeah? And the most enormous improvement in the chance of being alive and with your cancer controlled at just approaching 2.5 years. Okay? The most enormous improvement from about 15% of people to about 80% of people. Okay? This was such a huge effect that there was an enormous debate, do we need to do a comparative trial? And people decided we didn't need to do a comparative trial. It would be unethical to do a comparative clinical trial. This shows what happened to those people when they first started taking Imatinib. This is from arguably the best medical research journal in the world from 2002. This is a PET scan. This is somebody who has a great big GIST here. And this is, they start taking Imatinib, and this is the same patient's PET scan 1 month later. Yeah. The black area shows the active cancer that's taking up lots of sugar and growing and trying to live. And 1 month later, that's essentially just switched off. Okay? This is the power of a targeted treatment. And then some months later, after continual treatment, the mass has both remained largely switched off, maybe a little bit active on that far corner there, and got much smaller. We went on, of course, to refine what happens when we take Imatinib based upon the type of change that there is in the c-KIT gene, and identify some people whose changes in the c-KIT gene within the tumour makes they do slightly better with Imatinib, or a middle group, or less good. And I'll come on to this in more detail. But the fundamental thing I wanted to make sure you left here understanding was what an enormous effect Imatinib had on people living with GIST. Yeah, okay. And how that was just really, really obvious. And that was, as I say, but so far, I hope there are more, but far and away the biggest thing that I've seen change in my career. So now we know that not all GISTs have these c-KIT mutations. Some have other mutations. And indeed, we can begin to turn GISTs into different illnesses, yeah, with different subtypes. We take a biopsy of the GIST, we may remove it at a surgery or put a needle in it, send it off to highly sophisticated laboratories, it ships off on the NHS, it gets shipped off all over the country from place to place, and a result comes back which says exactly which type of GIST somebody has. Do they have one of the common ones? Do they have one of the rarer ones? Do they have one that runs in the family? Do they have one that might affect children? Do they have one that's associated with other illnesses? Yeah. So from those initial starts, we developed this detailed understanding of what Imatinib is. Some of you may have heard, some of you know very, very well about what's called pediatric or adolescent or wild type GIST. And I wanted to just put a slide up because wild type GIST sounds very scary, I think. Yeah. It sounds like it's something that should be in a jungle, yeah, and is in danger of eating you. Yeah, okay. So I'm trying to encourage my colleagues to stop talking about wild type GIST and stop putting wild type GIST in their letters. Yeah, and say something which is a bit more verbose, something about GIST with a without an identified mutation change, because I think it's more friendly. What we then went on and worked out, the scientists then went on and worked out, was that actually what sort of gist you had made a difference to the natural history of your gist, whether you were needing imatinib or not. Yeah? So if you had one of these changes within your gist that was very sensitive to imatinib, you're more likely to remain free of your gist as well. Yeah, okay, so this doesn't only inform the decision about using imatinib and other medications. Yeah, this biology informs the decision what happens to the cancer naturally as well. Yeah, so this is incredibly useful information, and mutation typing in GIST has been established for quite a long while. It is a little technical, and I fully understand that, of course, but it is incredibly important. Then the French group, we had all these people and they were taking imatinib, and they were doing miles better than they had been ever before, and everybody was delighted. But there were side effects, as Alex has just said, and we began to turn our mind to, do you need to take the imatinib continuously when you're on it and it's working? Yeah, okay. For anybody who's in the room who's taking imatinib and finding it difficult, it may well be controlling the illness, yeah, but it's also not very pleasant, and it may have controlled the illness for a long time, and so having something that you're not finding all that easy to take for a long time, can you stop and change it? And actually, I don't know how many people use this in clinical practice, but the answer is yes, you can. As long as you're under careful monitoring by an experienced clinical team, you can stop it. Yeah? It's likely that if you stop it, in fact, it's very, very likely that if you stop it, your GIST will reactivate again more quickly than if you remained on it. Yeah? But if you then go back on the imatinib again, yeah, once it reactivates, the chances are very, very high that you'll remain you'll get back to being just as well as you were before and continue just as well as you were before. Yeah, okay. So you can have a treatment holiday from the treatment. Yeah, and as long as you're under careful monitoring, that's perfectly safe. We've already heard a little bit about the adjuvant trial. This is one of the adjuvant trials, and this has some important messages in it. Adjuvant treatment. So somebody's had a cancer removed, yeah, and as far as we can see, the surgeon's gone right the way around the outside of the cancer, not left any cancer inside the person's body, yeah. So a resection with a clear margin, as the surgeons say, yeah. But that isn't the end of the story for many cancers, sadly, GIST and other cancers. It is for some, but not for everybody. Yeah, okay, so I compare cancers to a dandelion clock in your lawn. Yeah, you can take that dandelion clock out of the lawn, put it in a bag and take it away, yeah, but you may or you may not get other dandelions around it in the time that follows. Yeah, and that's because some seeds have flown off that head before you took it off in your lawn. Yeah, okay. You may not be able to see that from looking at the dandelion clock, the seed head very closely, but it may or may not be the case. And time will tell, yeah, whether that's happened. Yeah. So adjuvant treatment is having a treatment which might weed killer the whole lawn, even though you haven't got any dandelions at the moment. Yeah, and it just might help you not get the cancer back again. So adjuvant treatment, this study, the Scandinavian, and compared people taking imatinib for a year after chemo, after surgery, with people taking imatinib for 3 years, yeah, for patients who were at significant risk of getting their cancer back. They had a large tumour, one that was active, or the tumour had already, unfortunately, come open at the time or before the surgery. They showed that that 1 year and 3 years of treatment were both effective at some level. They showed that having the treatment for 1 year was much more likely to be able to be completed fully than having the treatment for 3 years, where a quarter of people couldn't take the treatment for the whole 3 years. They had to stop it sooner. They showed that if you took the treatment for 3 years, here, you're higher up there, your chance of remaining alive was greater, out to somewhere around about 5 years. Yeah. So this did mean that people stayed alive who, without this treatment, may not have been alive. but it probably did not show that any of these people were going to therefore remain alive indefinitely and not ever get their gist back at some time if they were going to. So when we look at the number of people over 5 years who got their gist back at all, we saw the 3 years and the 1 year be relatively similar. Yeah? So we were delaying people getting the gist back with this treatment. Yeah? We probably weren't truly preventing it from coming back if it was going to. Yeah, we were delaying it. And that's positive. That's a good thing, isn't it? It's great to have that happen. Yeah? But whereas in some other cancers, for example, probably breast cancer, probably bowel carcinomas, if somebody has an adjuvant treatment, they seem to increase the number of people who never get the illness back. Yeah? Here we seem to be delaying rather than shifting that. There isn't, and I just put this wordy text at the bottom here, there isn't very good evidence that this adjuvant imatinib approach works for patients who don't have an exon 11 change in their c-KIT. Okay, so again, that biology matters for patients in those other groups. Go on. See, please. What does that mean? What does that mean? It means that when you have your biopsy taken or your gist removed and you get a result back from the laboratory through your doctor or nurse and it shows that the sample has been sent to another lab somewhere in the country or whatever, if you get the result that reads exon 11, yeah, and you're in a group who's at high risk of getting your gist back, it's a good idea to take as near to 3 years of imatinib as you can. If you get a result back that says that that you've got another exon, a 9 or a different thing, then probably taking that imatinib is not going to help you. Hmm? Go on, it's fine. Oh, so that's a different situation. So if somebody has got a gist that's already spread beyond what a surgeon can take out, then yes, it helps greatly. Yeah, and it helps somewhat depending on the different type of change. We then learned more about how to identify which patients are at which risks after they have surgery. So if somebody has a small gist taken out, which is not got lots of cells dividing inside it, then they have a low risk of ever getting their cancer back. But if somebody has a large gist with a high rate of change within it, of cell growth within it, they're at a high risk of it coming back. And your doctors and nurses will be able to tell you, if you're in a group where you've had a gist removed, what your risk of getting it back is. They'll be able to estimate that for you. Again, to answer the question that was asked a moment ago, this relates to somebody who's had a surgery, their gist has been removed. Yeah, not to somebody who's got spread of their gist or has their gist still inside them. Then this causes some concerns to some of the patients who I look after, so I thought I'd just bring it up briefly today. These are tiny, tiny gists, yeah, that are under a centimetre across, yeah. These are interesting and controversial. A lot of people have these, yeah. A lot of people have them. Perhaps up to a quarter of people have them inside them. Yeah, and they're quite often found at other operations for other reasons. Yeah, they're tiny, tiny little things. Yeah, nobody really understands them very well. And but it is fairly clear that if they have been removed, that's fine. They don't need further treatment. If you know that you may have one, it's controversial whether you should have a surgery for a tiny, tiny gist or not. Depends upon the side effects of that surgery. And if you and so these are difficult and controversial. So I raise them for that reason, because they're something for a detailed conversation with an experienced cancer team to see whether somebody who's got what people think is one of these tiny gists. And what we quite often do is we watch them for a while. Yeah, we may know that somebody's perhaps got one of these tiny gysts because it's come up on a scan. Yeah, and we'll just watch them for a while and see whether they appear to be changing, and if they're changing, get them removed. When somebody has a gist within them, like you were asking about, yeah, and they start Imatinib treatment, what happens to their gist on their scans is not exactly the same as what happens to other cancers on scans when you have a treatment. They don't always immediately get smaller. They don't always immediately improve. What tends to happen is on the scans, we see the gist go, what I tend to explain to patients as soft. This is a scan where within this person's gist, the tumour's got lots of darker parts that are soft, but a fair number of lighter white parts, yeah, that are solid. And after a short period of time on Imatinib, the tumour is about the same size, maybe a little smaller, but about the same size. But the amount of softness within it, liquid within it, is much, much more, and the amount of solidness is much, much less. This fools some X-ray specialists into saying that this cancer hasn't improved very much, yeah, when actually we know that if we wait a little longer on the Imatinib, yeah, the gist will then get smaller, and it will then improve. Yeah, okay. So the important message is that these changes need the detailed work of a multidisciplinary team to interpret them and decide whether somebody should stay on Imatinib or not. This is an example of somebody with a small area of gist within their liver, yeah, who started Imatinib, and the amount of gist appears to get more, quite a lot more, appears to get quite a lot bigger. Yeah. And quite often that will be reported as this appears to be worse. Yeah. But actually persisting, that just remains like that. And it's really important that people, when they start on Imatinib and they come for their first scan at 3 months and their second scans at 6 months and on as it goes, that's really thought about very carefully, and they don't too quickly decide that Imatinib isn't helpful. This is an example of a case where we didn't see something in the liver at all at the beginning, but there was something there, and because the Imatinib made it go liquid and visible, suddenly it was seen. So in this situation, a patient might be told, oh, you've developed a new problem with your gist, but you haven't. A problem you had initially has become visible. Yeah? And then this is what happens for some people when Imatinib is beginning to stop working. Somebody's got one of these soft areas within their gist, within their liver here, but inside it a new hard area or firm area is developing. Okay? And this is often not noticed by X-ray departments or called by X-ray departments as a problem unless you're in a very specialist centre. And actually it is the first indication for some people that Imatinib may be starting to not work any longer.
Is there any research being done on why Imatinib stops working?
Yes, there's a lot of research done on why Imatinib stops working. There's no research at the moment that tells us what we should do to prevent that from happening. Not quite true, there's no research, but there's no real answers to what we could do to stop that happening. A cancer consists of tens of millions of tiny, tiny cells, yeah, and you could view those like a population of bacteria in a dish or of rabbits in a field, yeah, okay. And if you damage one group, you give a competitive advantage to the other group, to another group, yeah. So, and then that other group thrives and replaces the group that you've set back. So, if you introduce a pesticide that only kills the rabbits with the longer legs, then soon you'll have just rabbits with shorter legs. Yeah, if you see what I mean. Yeah. So that's us promoting resistance by what we do, and how we get past that is $1 million question.
Focusing on tackling this very early on, so rather than necessarily resistance mutations at the earlier stages, so they don't have them. That's the idea of a lot of these trials.
I think that's fine. It's not quite preventing the resistance mutations happening, but it's trying to tackle them from the beginning. Yeah. Then we move to sunitinib. Sunitinib was the second-line treatment, as we heard, and was approved by NICE in September 2009. These are the trial of sunitinib against taking a dummy tablet. Yeah. And what we can see here is there clearly is a benefit for taking sunitinib over a dummy tablet, but it's nothing like the size of the benefit from Imatinib that was had from Imatinib in those early trials. Yeah, okay. And so these are two presentations, the published data and the initial data that came out at ASCO before. So sunitinib inhibits a range of targets. It is a useful drug, but it's not as dramatically effective as Imatinib was back before. We've touched on this. Not everybody has to have sunitinib at the same in the same way. Some people take it for some weeks on and then have a break, and other people have it continually. Yeah. What the data research suggests, is that the chances of being free of your GIST having grown are about the same whichever you do. Yeah. So this is mainly about side effects, but it does show that if you have your sunitinib and then you have a break and then you start your sunitinib again, probably your cancer does slightly reactivate during the break. Yeah? But actually, that might help you not get that resistance. Okay, and so this is interesting. So you might get longer from your sunitinib if you have breaks, but you might get some symptoms during your breaks sometimes. Yeah, and those might be real, but they may not matter if you then go back on your sunitinib again. And across the piece, you might be better that way. The side effects are clearly very different. If you take it continually, you get a different set of side effects with a different probabilities. I'll keep moving through. I don't want to take too long. This is then the next agent that came along, regorafenib, and this was significantly better than placebo. Yeah, significantly better than a dummy tablet. Regorafenib, another, the third-line drug currently. Okay, so again, the research showed that this was effective and well tolerated in patients who tried imatinib, that had stopped working, tried sunitinib, that had stopped working. And so now we begin to say, okay, we've got a range of drugs that have been tried. They work in a range of different types of GIST, yeah, to a different extent. Then we get to the very current agents that are controversial at the moment and subject to work at the moment. So ripretinib in the INTRIGUE trial, ripretinib after imatinib stops working, provides similar control of the cancer, yeah, but to sunitinib, but probably with fewer side effects. Okay, so this trial analysed that. Yeah, ripretinib was then also studied here in comparison with placebo. Yeah, with a crossover arm at the end in the Invictus trial. And that showed us again that ripretinib does shift the curve up to the right, does improve the control of the GIST, and does improve the length of life somewhat. Yeah. But this is what NICE said about it. They said that given that most people were going to remain on their ripretinib if it was their last line of treatment, that it was going to be too expensive for the public purse to pay for, and they passed it back to the company that makes ripretinib to say, can you reduce your cost? And then this drug will be able to be made more widely available. Avapritinib is also very interesting. Again, this is another randomized trial of avapritinib against regorafenib. Yeah, this showed that in the whole group of patients, avapritinib was not much better. But in the group of patients with specific resistance mutations, it was a lot better. So then a trial was done in the group of patients with mutations that were highly resistant, and this was with this particular exon, this exon 18 thing, and here the cancer was made much better with avapritinib, and so this does look very promising. But again, NICE wanted to cut the cost to the taxpayer and get this drug forward in its own way, whatever we might think about that. And again, they said that, that it wasn't plausible, that it could be cost effective, that it would be give enough benefit for the price the company wanted to charge for the drug. So they passed it back to the company to say, please will you reduce the price of the drug, and then it can have a place on our NHS. And so then I put this up, which shows that Imatinib is now featuring in American systems for a fourth-line treatment. So it will come here as a fourth-line treatment. Imatinib still features in specific situations, even in the American system at the moment. Yeah. So therefore, the American system where, of course, people are paying out of pocket or their insurance companies are for their medicines. So just some very brief slides about clinical trials, some of which, thanks to Ramesh for these slides from Cambridge, because he shared them with me. Some of this is a little bit out of date as to which of these studies are exactly open today, but this is Imatinib versus Sunitinib in patients with exon 11 and other mutations who've been previously treated with Imatinib. So again, to ask your oncologist to ask for referral for a trial if you're in that position. If you're due to start Sunitinib. This is the one we've just heard about. This is a French study using immunotherapies in GIST in an early phase, so only for patients who are ready to consider really much more experimental approaches, but ready to try that. And this is some people trying some radiotherapy approaches, to try to give selective radiotherapy to patients with GIST in the liver. Again, if you've just got GIST in located areas of the liver and you feel ready to try a very experimental approach to the treatment of your GIST, then think about talking to your doctor about this. This is a trial we all thought we were going to open, but which was stopped. This was a further KIT inhibitor, which was stopped. It wasn't stopped, as the rumours went around slightly, because they didn't want to look after people with GIST. It was not that. It wasn't stopped because GIST is very rare. It was not that. It was stopped because it was much too poisonous a medicine. Yeah, okay. So it was stopped to help everybody, not stopped to harm everybody. And I think the rumour mill sometimes goes wild about that a little. Yeah. There are these other trials, but I don't touch on them now in any detail. These are for people with even rarer subtypes of GIST. Some of these for people who have GIST that runs in the family, or GIST that began when they were very young. Yeah, okay, or GIST that is part of a familial condition. And these are studies that are open. Some of them are open in the UK, some of them open elsewhere. Yeah, and these are for those GIST that have very rare biological changes. So a quick run through from what it was like to have GIST and to look after people with GIST way back when there weren't any options, to what it was like for Imatinib to be discovered and how much that helped. So the information that let us now use Sunitinib and Regorafenib in addition, and to where we may be heading with other drugs as well in the next short while. And I hope that's helpful in some way. Thank you.